lumbar microdiscectomy is typically performed for a herniated disc. A herniated disc can cause compression of the nerve root, which we see in this model here. These are the yellow pieces of plastic symbolize the nerve root as it's coming out of the spine. Now, people that have lumbar radiculopathy will frequently start out with common low back pain. Most of us will have low back pain at some point in our life. About 85% of us will actually miss some activities or work because of low back pain. Most of the time it's not very serious, and most of the time it just requires minimal or no treatment, and that typically gets better. On occasion, the disc can bulge out from where it should be. The disc is a cushion that sits between the vertebra bones and provides space to allow the nerves to exit, and again absorb some of the shock of our daily living. Occasionally we'll get a weakness on the outside of that disc, and that'll allow the softer inner portion of the disc to escape from its normal confines and squirt backwards and then start displacing one of these nerves. And when that occurs, that causes a characteristic pain, numbness, and sometimes weakness. This diagram shows a depiction of a disc herniation. In this disc, the disc is pushing out from where it should be out into the hole, or what we call the foramen, where the nerve exits. And you can see that the nerve is somewhat displaced. And that's where we get our dysfunction of the nerve root, again with pain, numbness, and sometimes weakness. When the low back pain does develop into a disc herniation, the patient develops a condition called a lumbar radiculopathy. That is where one of the nerves is being compressed. The radiculopathy part is the clinical term we used for that nerve being sick, or in this case being sick from compression. Most of the time when that occurs, we do relatively conservative measures to treat this. Sometimes we do just minimal activity, such as a very short period of rest and activity modification. Sometimes we add medications. The medications take various forms. Most commonly we'll start out with an anti-inflammatory medication such as Advil or Aleve or Naproxen or ibuprofen, or the generic names. These are obviously easily obtainable, and most people tolerate these medications without much problem. Occasionally we'll give a course of steroids that are taken by the mouth, and these are at a tapering dose and sometimes are fairly effective at alleviating a particular exacerbation of pain. Other times we'll use muscle relaxants because sometimes these nerves being compressed will cause the muscles around the spine to be in tension, and they can develop spasm, and the spasm itself can cause severe pain. Other times we'll use a type of medicine that we call a neuromodulator. A common name is gabapentin or Neurontin, and that helps alleviate some of the pain transmission in the nerves themselves. An additional modality of treatment is an epidural steroid injection. These are somewhat controversial. I typically use them in my practice for somebody who has a severe exacerbation of pain or radiculopathy that we're not really able to control with some of the more conservative techniques such as manipulation or the medical treatments we talked about. With an epidural steroid injection, we have one of our consultants will actually introduce a needle under X-ray guidance into the spine just on the outside of the nerve sac, either through the back here or actually through one of the holes at the side where the nerve exits. They'll inject some of this long-acting steroid, which acts as an anti-inflammatory agent, which can help mediate the pain. The steroid injection itself does not actually cure the problem. In other words, it doesn't make the disc dissolve or regress, but it can provide pain relief while we're trying to give this some more time to avoid surgical treatment. When a person has been treating with their primary care provider and has failed to improve, usually after about 4 to 6 weeks of substantial pain, it's recommended they undergo further imaging. This would include an MRI scan, or possibly a CT scan, or possibly a test called a myelogram. The MRI is the most common test. It shows us very good detail of some of the tissues. There's also some advantages to having a test called a myelogram or a CT scan. We tailor the study order to the specific needs and the specific clinical situation for that patient. When patients have failed conservative treatment, as we talked about, then we would think about surgery. Surgery is done early or on an urgent basis in rare occasions. This is when a patient has a large disc herniation and they start having trouble with controlling of their bladder or sphincter function. If that occurs, then we proceed very aggressively. Now that's very uncommon. I've been in practice for more than 20 years and I've actually only dealt with a true syndrome like that twice. Another condition that was prompted us into prompt surgery is a progressive motor deficit. That means you're developing a weakness that's worsening. The most common thing we think about is a foot drop. That's where one cannot walk on their heels or their foot flops when they're walking. If that is progressive, frequently we would consider doing surgery fairly early in hopes of preventing that from becoming a permanent type condition. Most of the time, the decision for surgery is an elective type situation where the pain is continued, the numbness is continued, it's preventing somebody from going to work, it's preventing somebody from doing their activities of daily living, they can't take care of their kids, and so on. In those cases, then we would discuss the options for surgery. The most common option we use to treat a herniated disc is a procedure called a microdiscectomy. The microdiscectomy is a small procedure that's almost always done on an outpatient basis. With a microdiscectomy, what we do is we expose the spine by making a small incision of approximately 1 inch to 1.5 inches. We'll use some small retractors to get us access to where we need to be. Under a microscope frequently, we will drill a small window in the bone and we'll take a little bit of the connective tissue. We'll be able to see the nerve root that's being compressed. We'll gently move that nerve root away, and then we'll find that piece of disc that's compressing the nerve. And then we would remove that piece of disc with some instruments we have available in the operating room. That decompresses that nerve, and typically the nerve tends to recover fairly well. Now let us take a look through the actual intraoperative microscope. One can see the disc material down below, and now on my left hand is a sucker. On my right is a small scalpel, which I'm using to open the outer portion of the disc called the annulus. This is tough fibers, and when we get through that, we see some disc fragments that have been compressing up against the nerve root. The nerve root is in the top of the screen and is being held back by a retractor gently. This is a device called a rongeur that is used to remove the fragments of disc from underneath the nerve root and into the disc space. We're retrieving these nuclear pieces to prevent recurrence and provide a good long-lasting result. We don't take all of the disc because that would require a fusion for this type of operation, and generally the patient does very well with a much more conservative operation as depicted here. Here we're slightly moving the microscope to get a little bit better view. These are precision instruments that are very balanced and allow us to, with one hand, manipulate the scope. This was just another type of biting type instrument called a kerrison to remove a bone spur that was pushing up against the nerve root as well. Here we can see the finished product. The nerve root is now completely decompressed. You can see the little vessels on top of the nerve root. Beneath the sucker, one can see the disc space there, one can see it better, and there's no further mechanical compression against this nerve root. When somebody goes home from an operation like this, typically we'll give them a small amount of narcotic pain pills. Usually we inject some local anesthetic into the muscles and tissues around where the surgery site is, and that controls the pain very well for a short period of time. When the pain is returning, we'll either use again some anti-inflammatory pills, which we discussed earlier, or again a prescription for some narcotic pain pills like Narco. Those are typically helpful, and we would rarely have to use medication stronger than that for this type of procedure. The operation typically takes about an hour. The patient usually gets to the hospital about an hour and a half to 2 hours before the procedure. They'll be prepped by the anesthesiologist and the nursing staff in the operating room. And then we go back to the operating room, the procedure is performed. When it's completed, they go to a recovery room where they wake up and they're monitored closely. And then we'll go to a second stage recovery room where they'll meet their family again. We'll get them something to eat. We'll make sure they're up and moving. We'll make sure they're able to use the restroom and make sure they're able to be reasonably comfortable. When their pain's well controlled and we're satisfied with their progress, almost all patients go home the same day. When they get home, we want you to do light things around the house. We do want you to walk. We do want you to do just general minimal activities such as that. We don't want you to just lay in bed all the time. Prolonged sitting is also not advised. We do want you to vary your position. I do get questions as we see a lot of patients from out of town. It's reasonable to take a 2-hour car trip or so to get home, but we do want you to get out of the car or so once maybe and walk around if you can. And that kind of makes things a little more, loosens you up a little bit. Post-operatively, when the disc surgery is completed, the patient may experience immediate resolution of their leg pain. Some people have pain that lingers for a while. There also is a subgroup of patients that will have a basic honeymoon where they'll have the pain will resolve, and then as the nerve's basically waking up, the nerve will be irritated, and then some of the leg pain can come back, and then will diminish over a period of time. That's very common. It's very individual as to how the nerve root reacts after you take the pressure off. It has to do with how long the pressure was there, the age of the patient, whether they have diabetes or other conditions that may affect the healing of the nerve root. The lumbar microdiscectomy is a very common procedure and is performed very safely every day. There are complications with any surgery, and the lumbar microdiscectomy is not an exception. While these complications are uncommon, they do occur, and the patient should be aware of them. One complication that can occur is a recurrent disc herniation. When we do the surgery, we do remove the disc, but there still is a weakness in that outer portion of the disc, and some of the residual disc can re-herniate. That happens in about 4 to 10% of the patients. When that occurs, that sometimes requires a repeat operation. So that is probably the most common complication of this type of surgery. Rare complications includes actual damage to the nerve root. When the nerve is being moved over or gently retracted to expose the disc that's compressing the nerve root, then there's a small possibility of permanent damage to the nerve. There's a small possibility of a spinal fluid leak. This rarely has to be treated with another surgery. There's a very small chance of infection. We have well less than 1% of patients will get an infection from this procedure. If that occurs, sometimes it has to be treated with intravenous antibiotics. With any surgery, there are very small chances of other complications such as reactions to anesthesia, which are increasingly rare. There's even a chance of having a surgery at a wrong site. When we do perform the surgery, we do take intraoperative x-rays, but sometimes the anatomy is difficult to interpret, particularly in larger patients. We're particularly careful about that, and it's a very rare occurrence, but it's not something that's unheard of. Patients will frequently ask, what's the recovery? And again, the recovery is gradual, and the recovery is independent. Again, it depends on the general age, physical condition of the patient, how long they've had the symptoms, and their general occupation. We do talk about getting back to normal activities. These include just walking around the house, taking care of themselves. For the most part, people are able to be by themselves the next day. Occasionally it's nice if somebody's in a weaker condition to have somebody help for a few days, but for the most part, people are able to get around. We discuss driving, and driving can typically be done 1 to 2 weeks after surgery. Now, various surgeons vary their recommendations on that, but that's a general guidance factor for disc degeneration and a disc herniation. We also know that smokers need more spine surgery, and we also know they don't do as well as non-smokers when they do have spine surgery. So that's another major reason to stop smoking.